providing as well. So I work in conjunction with the oncologists and the surgeons and the radiation oncologists. It's not an either-or proposition. It's about hoping and planning simultaneously. And because there's this underlying fear of what might happen next, and how do I hold on to who I am as a person, these are the reasons why I'm often brought in early. So what is most important? You know, we look to extend life and to battle and fight the cancer. But why? There's a reason behind it. It's because there's something that we love in this life that we live. That we have certain values, certain things that are important to us. Family, cycling, music, art, meaning. We have fears that we want to address. We have sense of purpose and goals that we have in life. And all these things come into play, and sometimes if we get so focused on battling something or getting into a fight, is we lose track of those pieces of who we are. So part of my role in working with the primary team is to help hold on to these parts of ourselves that can sometimes get lost in the mayhem of care. So again, it's not an either-or, it's a both-and proposition. And it really comes down to the concept of hope. For every person in this room, that definition is different. For most people that are in this room, the reason why you're here is you're looking for ways of sustaining that hope. What else can we do? How else can I get care and treatment and make sure that I can live as long and as well as possible? For some people, it's about being out of pain and being as comfortable as possible. And whenever we think about surgery or chemotherapy or even antibiotics, we can have side effects. I had knee surgery last year, and I certainly was uncomfortable afterwards. I wanted to make sure that I would feel as well as possible. And boy, did that PT, they could certainly torture somebody quite a bit afterwards in the process. So, for any kind of intervention, there are side effects that we can have that can intervene with quality of life. So it's not necessarily about giving those up, but it's about having a team member who can help manage those symptoms and maximize quality, make sure you're out of pain. And one of the things that I think my colleagues here know is I tend not to be afraid of pain medicine. I mean, I have a healthy respect for it, but I will make sure people aren't suffering or in pain if they don't have to be. Nausea also. Any of these symptoms can come up, and I can help the primary team take care of them. And it's important to advocate for yourself. One of the things is, how many of you are long-standing New Englanders? So being in New England, we tend to be somewhat of a stoic bunch. We tend to, Annie, you mentioned that, you don't complain about pain very much. You were an athlete and tolerated quite a bit of things growing up and then later on. We tend not to want to let people know when we're uncomfortable. And unless it's asked, we don't want to bother Dr. Lambert. You're busy enough. I don't want to complain. You've done enough already. Why would I go and mention that I'm having ongoing nausea, or this is uncomfortable? Or perhaps I'm afraid of asking for more pain medicine because I'm afraid that perhaps I'm going to be perceived as an addict, or I'm asking for it for the wrong reason. So this is when advocating for yourself, the only way we know that you're uncomfortable is if you let us know. Especially for those of us who are stoic, because you know how to maintain this face that doesn't show a thing. You're good poker players. And so then we bring in this concept of palliative care. And how many of you have heard the word palliative? A few, about half the room has. Very often it's brought in and people perceive the word as palliative as being when no more cure can be offered, or when no more aggressive therapy is offered. It's considered often an either-or proposition. But this is the World Health Organization definition of palliative care. It improves the quality of life of patients and their families, including their other half, sisters, wives, husbands, children, grandparents. And I'll share one quick thing. There's a patient I'm taking care of, an elderly gentleman who moved back to New England to be with his family after living in Florida for some time. And he's in the hospital. He's been a widower for many, many years. But one thing that was very important for him to share with me was that he had a lady friend in Florida while he was down there, and they became very close. Just as he was getting weaker and came home to be with his family, she went to Wisconsin to be with hers. And they talk on the phone quite often, but they haven't seen each other in a while. So one of the things that we're organizing is getting a Skype conversation where they'll be able to actually physically see each other through the computer and talk for the first time in a couple years. You know, it's not rocket science, and it's certainly not surgery the way that Dr. Lambert, Dr. Alexander, and Dr. Whalen do. But it adds to quality of life and meaning and purpose and can help keep people going for that next day and tolerating what we're going through. We help people who are dealing with serious illness through the prevention as well as relief of suffering. And as you can see here, it's early identification, impeccable assessment. And this is all the way along in the spectrum. So it's not just when nothing else can be done, but it's in conjunction with. And the new paradigm is really around this, is that palliative care works in conjunction with curative and restorative therapies. And so we're here throughout the process, and we'll continue to support all along there. And very often, when people do well, one of the things we're talking about here is also in our cancer centers, even including palliative care and survivorship. Because when we have been diagnosed with cancer, our perception of who am I shifts, and our relationship with the world and stories changes, and somehow is a little bit different. So there's quality of life and meaning and goals and hopes that shift, not only if disease progresses, but also through survivorship. So hope also includes the possibility, the aim to live as long as possible, and the aim to live as well as possible. And sometimes they work together, and sometimes they can come across as a little bit of conflict. After medical school, I spent a little bit I did some work over at University of Southern California. That's why I had the Fight On sign there. And we've had patients who I come into the service with, certainly with many of these physicians here, whose wish is to fight on to the very end. But in order to do that, they need impeccable symptom management and a sense of purpose and a meaning. Why am I fighting on? What am I aiming towards? Why do I keep on going through this process? And then what happens if that fight shifts? What happens if? The what ifs. And we're here to support you with the what ifs and the hopes. For some people, the hope is to fight for that extra day, that extra year. And for other people, or the next round of chemotherapy and treatment. And again, why? Sometimes it's to get married. Sometimes it's to see a grandchild born or a grandchild to get married. There are lots of different reasons why, and sometimes the story behind it gets lost in the care that we're getting. And here's a patient of mine who was in a hospice, and her son had brought his bride, who he met when he was working down in South America, up. She had a very short window with a visa to visit and meet her future mother-in-law. But he said, there's no way we can pull a wedding together in these 2-week period. Well, we made it happen. In 2 days, we found a cake, a dress, champagne was donated to us, and we got our chaplain to come in, and we threw the whole wedding together right at her bedside, so she was there for the wedding. So things can happen around goals and wishes and hopes that can really, and we've had weddings right here in the hospital. One of Dr. Lambert's patients got married right in the hospital. He'd been engaged for 7 years, and it was really important for him. So we threw it together. I don't think there was a dry eye in the room. We were all crying with tears of joy while we were watching this whole event, and it was very meaningful. So these are the things that we help coordinate. For some people, hope is around spending more time with family. But at the same time, how do I do this and not be a burden? You know, we don't want to lean too much on the people that we've been caring for. And for some people, hope is around leaving a legacy. How do we keep our stories alive? How do we impart the memories and the shared experiences and everything that we want to make sure everyone remembers? How do we keep those pieces alive? Not only our financial legacy, but our ethical legacy. And this picture is hard to see, but there's a website called 1000memories.com that a few young .comers in social media built after one of their college classmates died. And it was a way of keeping his memories alive. But this website has shifted. It's not just a retrospective memory, but it's a place where, for example, Lance Armstrong collects stories of him and his friends. And he's still bicycling, right? He's still doing pretty well. But it's a way of collating stories and making them real and allowing other people to contribute. Whenever we're dealing with something that's frightening, I share now with a lot of my patients to allow families, engage this, because when they come out of this surgery, what an incredible gift to have the families and the children and the grandchildren and nieces and nephews to say, look at all the things that we wanted to tell you, how we think of you. So that when you wake up, you have these stories and this incredible sight to look at. So legacy is there. For some people, hope is around spending more time at home rather than in the hospital or clinic. There can be a time when that becomes important. And for some people, it's about going to Las Vegas. How do we go to Las Vegas when we're not feeling so well? And this is one reason why I wanted to bring up the next kind of dirty word in this whole talk, which is hospice. Hospice use, very often we think of that word as really being for when people are imminently dying, when people only have days or hours left to live. And the reason why is because most people only sign up and choose hospice when they only have days to hours to live. But this has changed over time. We have hospices now that are open access, that allow people to get chemotherapy and radiation therapy and nutritional support while they're getting hospice care at home. It requires that if things progress untreated, that we anticipate somebody perhaps not having on average 6 months to live. But I've had people on hospice for 8 years, and I've had people graduate from hospice because they're doing well. So it doesn't mean that you're signing up to only have 6 months to live. It's saying that should things progress the way they are, there's a possibility that that might occur. And that I want to try and maximize my quality of life and time with family. I've had people who work full-time on hospice. You can leave, unlike regular visiting nurses where you're required to be home all the time. And that's one reason I brought up the Vegas story. I had a patient who said he was a gambler and he wanted to get back to Vegas. So he flew to Vegas while he was on hospice, and the hospice team met him in his hotel room and said, do you have all your meds? Got everything you need between going down and gambling? They have quite a bit of services and 24-hour support. And they also provide support for family afterwards. And the reason why I bring this up, too, is because for a majority of people in Massachusetts, one of the things when we get diagnosed with cancer is there is in the back of our minds, am I going to die? And what if? And how do I think and plan about that? And having that choice, the majority of people want to be home when that time comes, but only 26 or 27% of people in Massachusetts are home. So how do we match those goals with when that time comes, however far off it is from whatever cause? And it really is around having choice. We support people based on their values to get the care that they want, wherever they want to be. And part of our role is to help make sure that those values and wishes are met. And there's a project called engagewithgrace.org, which facilitates a discussion with the people that you love. Because here in Massachusetts, the decision-making, a living will doesn't count. You have to have a healthcare proxy. And filling out and naming someone to make your decisions might not be enough, because if they don't know what you want, they're guessing. This is a tough and painful and depressing conversation to have, but I tell you that I've had people who talk about it with their 9-year-old and 13-year-old children in case something happens. That the ability to have this conversation with people so that people know exactly what your hopes and wishes are takes away the stress when that time comes, whether it's near from now or far off. So I encourage you to look at this website and have the conversation. Hopefully that decision doesn't need to happen for a long time. This is a tough one, but really what we're looking at is supporting you through the difficulty and the fears and the uncertainty of what this diagnosis carries to maximize your personhood, your sense of purpose, your sense of well-being, what's important to you, what's valuable to you, and to design healthcare to support those goals. We'll be with you and support you through thick or thin, no matter what, and cheer with you when there are successes, and support you when they're not. And we'll hope for the best, but prepare for everything else. Thank you very much.